The broadcast is now starting. All attendees are in listen-only mode.
Okay, everyone, welcome to this webinar brought to you by the Mold Illness Made Simple course. I'm really excited to have Dr. Sonia Rapaport with me today, who's one of the certified Schumacher physicians, and we're also hoping that Dr. Raj Patel, who's another certified Schumacher physician, will be joining us later on. How are you, Sonia?
I'm doing just well. How about you, Sandy?
I'm great, thanks. Been a bit of a crazy week, but it's always that way when you have a whole lot of patients with CIRS and other illnesses like that. And I imagine you're fairly busy in your practice as well. Very
busy, and this week has been a little bit more of a challenge with everyone having a little bit of what I call PETSS, or post-election traumatic stress syndrome.
Yeah, right. Yeah, that must be quite severe where you are. Even here, we're noticing the effects on people, and certain people are feeling really anxious about it.
Right.
But you're right in the middle of it there. So anyway, we're going to jump into talking a little bit about what we're going to cover today. So really, we're going to cover some new information, we hope, for the majority of you. And we hope this information is going to help people who are either suffering from Lyme disease or a Lyme-like illness, or think they may be, and wondering how chronic inflammatory response syndrome could be tied in with their Lyme-like illness. So if you may be willing to close your browser tabs and windows and put your phone on silent, that will allow you to make the best use of this webinar. And have some pen and paper ready, because you may like to jot down a few points. All right, so today we've got myself and Dr. Raj Patel, who we're hoping will be joining us shortly. He's currently in Florida, and we're hoping he's going to be able to get on, and Dr. Sonia Rapaport from North Carolina. So I'm just going to spend a few moments talking about the Mold Illness Made Simple course. Many of you on the call will already know about it, and some of you will have already joined up. But really, this is a 8-week on-demand online course, which means it's something that you can do in your own time and scroll through at whatever time of day suits you. So there's 18 chapters, which are usually delivered over 8 weeks. And generally 1 week is opened up to you at a time while you go through this course. And each week consists of video lectures, workbooks, PowerPoint slides, and multiple choice quizzes. And there's also a private Facebook group, which we just opened up yesterday, and exclusive webinars like this one. And one of the big purposes of this course is really to focus on the emotional side of people who are suffering with CIRS, and try and help people to move a little bit from confusion and overwhelm and anger and despair slowly towards some emotions like clarity and calmness and peace and hope, because I feel that the emotional side of CIRS is very under-recognized, and in many ways it's on that level where people have to make the shift to be able to get well, because where there is despair, there tends to be paralysis, and where there's paralysis, we tend to not move forward. Have you noticed, Sonia, with your patients, that the emotional side of CIRS seems to play a large part?
I think it's a tremendously significant part. In fact, an absolute important part of treatment is to address those issues, and there are multiple different ways it can be done, but unfortunately, there are too many people who are suffering from CIRS without the support they need from family members, from fellow employees, from workplaces, from where if they're renting from their landlords, and it becomes even more traumatic.
Yeah, and I think Dr. Bernstein said at the Irvine conference that he didn't know of any other disease that had so many challenges. And one of the biggest challenges is it's not accepted by the majority of physicians, and even most people have not heard of it, and therefore it's difficult for people to be accepted and understood. And I think one of the biggest needs of someone with a chronic illness is to be understood and validated. I think that's a big part of your practice as far as I understand, Sonia. Do you want to talk a little bit around that?
Oh, certainly. And in fact, one of the things that attracted me to treating individuals with CIRS and to make the diagnosis is the fact that we actually have biomarkers. We have the means to help validate their symptoms. A typical patient has been seen by at least 10 other doctors. I've seen patients who've had 50 other doctors that they've seen before they've come in to see me. And unfortunately, too many of them say, well, we can't find anything wrong with you. It must, you're fine. Or these tests are all normal. And to be able to do testing that shows, no, you do have an inflammatory response. Your immune system is pushing an innate immune response. And the best part is as we treat and those values improve, they feel better. So it's a very validating experience to be treated by a CIRS-aware doctor. It's also just being heard and knowing that you're not the only one who's experiencing these funny symptoms that people shake their heads over, but that it's part of this whole picture. It's very validating.
Yeah, absolutely. And do you find, Sonia, that when you have patients come in for the first time and you start explaining to them about this inflammatory response syndrome, that there is a degree of overwhelm for them in just trying to understand exactly what's happened and understand some of these terms such as C4A and TGF-beta and this other alphabet soup that goes along with CIRS?
Certainly. It's not just patients. I felt the same thing when I was first learning about this process. So, in fact, I learned about CIRS from several patients who had initially seen Dr. Shoemaker, and they came back and were talking about their MSH levels and their C4H levels and their TGF-beta1 levels, things I had never heard before. So certainly can be very, very overwhelming. We try to work with patients by giving them handouts, trying to point to places where they can learn more about it, trying to teach them in the office. And that's one of the real values of your course is that people can take the time in their own home, in their own time frame, in their own pace to learn this and understand not only what's going on in their body, but how they're going to heal from it.
Yeah, and I think that is one of the big points is that when you can see a sort of a roadmap, and it's kind of like when you're traveling to a distant destination, but you've got your GPS dialed in. There's less anxiety because you realize that if you just follow the process, eventually you're going to get somewhere. And I think a big part of this illness, I don't know if you've experienced this, Sonia, is people really are worried about whether they're ever going to get their life back. Sometimes people are worried whether they've got something worse going on, such as cancer. And really there's a lot of fear going on in the background. And so the hope is that by explaining the CIRS treatment protocol and explaining how it's a sequential process towards improvement, that people can feel a lot less anxiety. Do you have any thoughts around that?
Totally in agreement with you. Certainly who said the only thing we have to fear is fear itself. And I came into more of an integrative approach to medicine because of my own children. I have 2 children who have a genetic disorder that was misdiagnosed, and the worst part for me as a parent was just not knowing what was going on, and that fear of the unknown is probably the worst thing of all. And once I was able to make the diagnosis, there was a relief. Now, I didn't like the diagnosis, but at least, as you say, I had a roadmap, a way that I knew what to expect and what I could do to try to help them. And it's the same thing with CIRS, with really any illness. The only caution I have is that we get calls from people who want to consider coming to our practice to see me or to see Dr. Braid, who was also recently got certified. And often people will say, what's the protocol that you use? And we absolutely follow the Shoemaker protocol. But when people come in with other illnesses like Lyme disease or POTS, postural orthostatic tachycardia syndrome, autonomic dysfunction, etc. We have to start thinking about them not as part of a protocol, but as individuals. And that's where some additional individualization comes into play.
Right. So you could say that there's kind of like a standard roadmap, and then there's some little optional extras that are added in according to the person's individuality. Is that a reasonable way of putting it?
I think that's a great way of putting it. Do you want to stop at this roadside rest, or are you going to move on to the store down the road? Absolutely.
That's the one. Okay. So moving right along here. Just going to share a little bit of feedback that we've received about the course, which has been quite heartening to date. And generally people have said that. So one person said, this course is really well done. I'm so impressed. Thank you. Another person said, the course is exactly what I need to receive a better understanding of what is happening, and like you said, offer clarity and hope. So far, the people who have been doing it do feel that it's allowed them to get their head around CIRS and feel that it's not so overwhelming and confusing, and just to break it down into bite-sized pieces. And so that's encouraging. So we'll get back to this in a moment, but we're going to do a little bit of a discount for the course for people after this webinar to be able to get 25% off. So jumping onto the subject of Lyme disease a little bit more, we'll just switch over presentations here. Okay, so just talking about some of the causes of CIRS. As you can see in this diagram, up the top, the most common cause of CIRS is water damage building exposure. And that's a very common condition. It's actually kind of unbelievable how common it is. I don't know if that's your feeling, Sonia, but it's almost like once you started looking at it, it's like, holy moly, there's just so many people who have this condition. But there are other conditions that can cause CIRS, or other causes, and one of those is Lyme disease or babesiosis, which both come from tick bites. But sometimes they can come from other vectors as well, such as bed bugs or lice, etc. There's a little bit of evidence to suggest that sexual transmission or vertical transmission from parent to child may be an issue as well. But this is an area for further research. And then there are some other rare causes such as algal blooms and ciguatera, which I don't see so much. I don't know if you do, Sonia, over there on the east coast of the United States.
Not a whole lot. We do see some more in the way of dinoflagellates, certainly. The original dinoflagellates were found up with Wisteria up in Maryland, which is only 2 states up, and certainly there was quite a lot in the estuary waters here in North Carolina, but I don't typically see that. And I may have seen one case we're working on right now that may have started with ciguatera, but almost far and away the majority have water damage buildings, and even the individuals who have Lyme disease. So one comment I would make about this diagram is that, well, there are 4 distinct etiologies or potential causes for CIRS in an individual. It may be more than one of them. It's very common for my patients who have Lyme disease to also be exposed to water damage buildings, and it just compounds the problem.
Right, yeah, so that's a really important little comment there, that even if you have Lyme disease, that's not to say that something like a water damage building couldn't be the cause of your symptoms at the time. So that's where it becomes tricky, and we'll go into this a little bit more. So I'm just going to talk a little bit about Lyme disease for those who may not be as familiar with it. Of course, many of you on the call may be actually experts on Lyme disease, but it's considered to be the second most likely biotoxin source after water damage buildings, and it generally occurs after a tick bite. And really the main bacteria which is responsible for Lyme disease, which is called Borrelia burgdorferi, was discovered in 1975 in Lyme, Connecticut, which is in the northeast United States, initially described by Alan Steer, who was a rheumatologist, and then actually isolated by William Burgdorfer in the early 80s. And it's a spirochete class of bacteria which is similar to syphilis. And apparently William Osler, who is one of the forefathers of modern medicine, said, "To know syphilis is to know medicine." and some proponents of Lyme disease from ILEDs have suggested that the manifestations of Lyme disease can be so widespread that perhaps to know Lyme disease is to know medicine. But interestingly, there is a very close overlap of symptoms with chronic inflammatory response syndrome due to water-damaged buildings, and perhaps the overlap is 95% or more. And it's worth noting that 20 or 30%, and that's probably an underestimate, at least 20 to 30% of people who contract acute Lyme disease end up having chronic symptoms. Any comments around that, Sonia, you'd like to make?
So it's really difficult where I am to really, I think, to tease some of that out, because since there are so many, there are quite a few physicians in my area who don't believe Lyme disease exists in my state, despite what the CDC says here in the United States, that people will often say, oh, you must not have Lyme, and so we don't catch them at their acute phase to know, well, yes, you got it today, or you got it last week with that tick bite. Most of my patients who I see who have had chronic symptoms that we determine are due to Lyme disease or borreliosis have had it for a while, and it becomes a much bigger challenge to figure out when they were acutely ill. But there is a tremendous amount of overlap, and as you say, it makes it a little bit of a challenging trying to determine what's the actual cause and what do we treat. And fortunately for the surviving mold protocol, treatments are really similar with some taking some things into consideration.
Mm-hmm. Okay, so there's a lot of similarity there with no matter what the cause of CIRS is, the protocol stays very similar. So that's another really important point. A little bit about different species of Lyme disease. Of 30 known species, there's at least 3 that are thought to cause disease. Well, there's now at least 4. So Borrelia burgdorferi is the major organism in North America, but I believe last year there was a new organism called Borrelia mayoni, which was also discovered in North America, which has been found to cause a Lyme-like illness. And then Borrelia afzelii and Borrelia guerinii are the main species of Borrelia which are active in Europe and Asia. And then there's the relapsing fever group of Borrelia, which are pretty widespread throughout the world as far as I understand. And at this point in Australia, Lyme disease is not accepted. However, there's a research group led by Professor Peter Irwin who found that there is actually a unique class of Borrelia that exists in Australia, and they've been found in echidna. Do you know what an echidna is, Sonia?
No, I don't.
It's like an anteater. It's a spiky little marsupial, and they get certain ticks on them, and they were found by this group of veterinary scientists to have a unique species of Borrelia last year. So that's actually quite exciting, and there's quite a lot of debate going on in Australia as to whether a Lyme-like illness is occurring and what the cause of that is. And there's actually a Senate inquiry going on right at the moment. So it's certainly a very interesting debate, and it's quite possible that at some point we'll isolate a specific species of Borrelia unique to Australia that does cause disease. So that's really interesting. Anything more on that, Sonia, you'd like to add before we go forward?
Well, certainly, one other Borrelia that we have is relatively new in the United States, was identified even before the Mayonii, is the Miyamotoi.
Yes.
And an article that came out in the Annals of Medicine that shows that Miyamotoi is doxycycline resistant. So here we have our prime acute treatment that most physicians will use is doxycycline orally, and Miyamotoi apparently is pretty resistant to that antibiotic. And the other thing is just that with travel back and forth, we do see some of these other forms in the United States. I'm sure that in Europe they also see some burgdorferi, some potentially some Miyamotoi as well.
Yes, right. So Borrelia miyamotoi is the causative organism of relapsing fever. Is that correct? I believe so.
There are several relapsing forms of Borrelia. The nematode, I believe, was identified, like I said, approximately 2 or 3 years ago.
Okay, and generally patients with relapsing fever tend to have more variation in their symptoms, is that what you'd say? And they tend to have fevers at some times that then totally disappear. So there's a little bit of a different profile of illness, is that right?
Correct.
Okay, so that's definitely one thing that's worth having on the radar and knowing about is relapsing fever Borrelia. And I believe there's some labs such as IGeneX who are now specifically testing for relapsing fever Borrelia. So a little bit about the controversy for those who don't know. Now, in most countries such as the United States, acute Lyme disease is acknowledged, while post-Lyme borreliosis syndrome or chronic Lyme disease is considered controversial. And really what we're talking about here is when people have symptoms above and beyond the initial 1 to 2 months after having a tick bite. And there's an organization called ILADS, which is the International Lyme and Associated Disease Society, who staunchly believe in the persistence of Borrelia after acute infection. And they have certain research which supports this view. While the Infectious Disease Society of America believe chronic Lyme disease is probably a misnomer and is actually due to residual damage or autoimmune damage. While there's many physicians out there who also just believe symptoms are due to depression or another psychiatric condition and are not real at all. So I don't know if you have any thoughts about that controversy that you would like to share, Sonia?
We, especially in my state, just up the road from where I practice, there's a physician who's one of the big names in the Infectious Disease Society of America that does not believe in chronic Lyme. And it somewhat baffles me that a physician could say that there is no chronic Lyme just because they can't culture something out. We've learned so much in the past 20 and especially the past 5 to 10 years about how organisms can live in persistent forms. They can have round forms where they're more or less hibernating. They can live in biofilm communities where the ability to culture the organism through typical blood culture means just isn't as good. You're not going to capture those organisms as well. So the lack of our ability to test with current means does not mean that it's not there. So I'm a firm believer that people can have persistent Lyme disease. I also do believe that Lyme can cause post-Lyme-like syndrome where the Borrelia is gone or quiescent. Maybe it's not ever gone, but it's not actively causing your symptoms, but your body's response to the past Borrelia or past Lyme disease is what's causing the persistent symptoms.
Okay, great. So really the testing is a big problem. And I guess with the evidence-based medicine paradigm that we have, it's very much based on having tests that can detect something. Otherwise, often there's not a belief in the existence of that condition. And that creates a lot of problems. So, for instance, chronic fatigue syndrome was not accepted for a long time because there are no good tests for this condition, but eventually it was accepted in general by the physician community, and it's possible the same thing will happen with chronic Lyme disease.
And, the U.S., one of the biggest problems that we have, I think, it has to do with politics and professional ego. And when one group comes up with a test and another group comes up with a competitor test and writes articles declining to accept the first test, it becomes a political mess. And unfortunately, I think that's where we are.
So I mean, it seems that like Lyme disease is one of the most political conditions in the history of medicine, really, one could say. And that makes the waters even more murky for someone who's trying to wade their way through it. So it is very tricky, and we recently had someone who was diagnosed with Bartonella infection, and then went and saw another physician who was quite well respected in the infectious disease community, and was told that was definitely not the case. He did not have any problems whatsoever, and that was an extremely confusing experience for him because he was starting to get a little bit of hope back, and then to be told that the diagnosis was rubbish or whatever, that can be quite disheartening. I don't know if you have any comments that could help people who've had those sorts of experiences.
Yeah, so I think the most important thing for any individual is to trust their gut feeling. I tell my patients all the time that there are two experts in the room. I bring whatever expertise I may have in different areas of medicine, but they're the expert in their bodies. And if something resonates and it feels right, if it feels like it's infectious, then I think that's the doctor you go back to. If you're starting to improve, that's the doctor you go back to.
Right. So in a sense, you're saying learning for people to trust themselves to a certain degree. And be able to just really tune into the feedback that their body is giving them is probably a really important key on this journey, because it's quite a maze.
It is. It is.
Yeah. So a little bit about the ILADS model of Lyme disease, and this is different to the Infectious Disease Society of America model, but the standard model is that Lyme disease is one infection, and then there are a whole group of co-infections that can exist on top of the Borrelia infection, which is what has classically been called Lyme disease. And some of these co-infections include Bartonella, Babesia, Ehrlichia, Rickettsia, Mycoplasma, Anaplasma, and some ILADS physicians even consider mycotoxins to be more like a co-infection of Lyme, and often the treatment is carried out according to this model, where co-infections are treated either first or somewhere down the line with the antibiotic protocols. And there are various different antibiotics and different protocols which are used for all the co-infections. So this is something that we'll also jump into. So I think starting to jump into the nitty-gritty of this a little bit more, would you like to talk, Sonia, a little bit more about how you tease out whether a person who is chronically unwell after a tick bite in the past, whether their problem is mainly due to chronic inflammatory response syndrome, or whether it may be mainly due to persistent Borrelia organisms, or whether it may be co-infections, or whether it could be something else totally different again?
So we have several options here in the U.S. Certainly the first step is to get a history. Beyond the symptoms that I'm sure you're talking about in this course, as well as the symptoms that you mentioned earlier, that 95% correlate between Lyme and water damage building as etiologies for CIRS. So the first step is to get the symptoms, and then to dig deeper about the history. Was there a tick bite? How long ago was there a tick bite? Was there a rash? Do symptoms come and go? Are people worse in certain environments, or is it pretty much the same all the time? And then we start looking at lab tests as well. There's some immunological markers that I look at. There are several options as far as testing for Lyme. Here in the U.S., and particularly on the East Coast, there are labs that do what are called antibody tests, so determines if someone's been exposed, if they have antibodies. There are tests that do a lymphocyte probe. It looks to see whether your lymphocytes react to Borrelia antigens, so pieces and parts and proteins of the Lyme disease bacteria. And if your lymphocytes have been around them in the previous 2 weeks, chances are that they will react. So it gives you a little bit of a picture of if you've had Borrelia in your system in the previous 2 weeks. It requires a good, healthy, or a relatively healthy immune system. If your lymphocytes aren't working well, then you're not going to be able to do that test. We have a culture here in the U.S. that we can send off, and it determines if it's Borrelia in general, but it can also determine if it's specifically Borrelia burgdorferi. We have urine testing and other kinds of body fluid tests that can determine if there's pieces of Borrelia protein in the urine, for instance. And there's a really interesting one called a nanotrap test that it concentrates these Borrelia antigens, these Borrelia proteins, out of the urine. It acts like a little lobster trap, attracting the with a bait that attracts the protein, and then they wash it out and they look to see if there's protein there. So we have several different ways that we can look at Borrelia. Some of the other co-infections are much more difficult to identify. Babesia can be very difficult to identify. There's antigen testing, there's antibody testing, the same with Ehrlichia, with Mycoplasma. Bartonella, there is a lab here in North Carolina called Galaxy Labs that does some really nice Bartonella testing. Unfortunately, it's not the most consistently positive, and so it may require 3 or 4 samples in order to get that positive. And then there are some other labs that have recently started doing DNA sequencing, looking for the DNA of these organisms, again, in different tissues and fluids. There's one lab that does it out of urine. There's another lab that does it out of blood. There's so much new work that's going on, and I think what we're missing is the good guideline to tell us which ones are the best tests to do. There are varying costs. The most expensive I know of is $1,400 per test, and so, you know, huge out-of-pocket expenses potentially. So what would be really helpful is a great tool to know exactly which was the best one to do under which conditions, but everyone's trying to figure that out. I don't think anyone has the best answer, the right answer for that.
Yeah, so the testing is a big gap, and Dr. Shoemaker has brought in the NeuroQuant testing as one way to try and help to solve this problem, and also the use of the C3A blood test. Have you found that in some cases, though, those tests can help to tease out whether how much of a person's illness may be due to a Lyme-like illness and how much may be due to mold?
In my experience, the C3A and the NeuroQuant are the most helpful in acute Lyme, and the chronic Lyme or more persistent Lyme picture, I typically do not see elevated C3As. In fact, that's a pretty rare occasion in my practice. And the NeuroQuant analysis, I think, is a really great acute Lyme picture when we're looking at the Lyme score. I think sometimes people who have mold and Lyme, perhaps the mold picture sort of takes over. Right.
Okay. And that's what I've seen as well. Probably 98% of the patients here who we have scanned have a picture more consistent with either mold or multinuclear atrophy. And just talking a little bit more about that, have you seen some patients who are more severe with tick-borne illness who show up with this pattern we call multinuclear atrophy on the NeuroQuant?
Yes, yes, we have. And again, with multinuclear atrophy, trying to understand what's causing that is the big challenge. We see clear changes on the brain that are, I believe, are associated with symptoms, and as we treat and people start to improve, the brain changes improve as well. But what causes that, I don't know that anyone has the complete answer for that. Certainly past traumas can be a significant portion of that, traumatic brain injuries, and even psychosocial traumas.
Yeah, so there's a wide range of things that could theoretically cause multinuclear atrophy, but the exciting thing that Dr. Shoemaker presented in Irvine at the conference was that it appears that no matter what the cause, more long-term use of the VIP nasal spray appears to have a very good track record of enlarging or re-expanding all of these shrunken brain areas that people have when they have multinuclear atrophy. Have you seen that occur?
We're starting to see that, and I absolutely agree with you. I think the research that Dr. Shoemaker is doing and Dr. McMahon's as well as doing out of Dr. McMahon's practice using VIP and showing just astounding corrections in these brain changes is really dramatic. It's one of the most exciting areas in medicine, and certainly in CIRS medicine.
Right. And just a quick word on MARCONs. So MARCONs, which are a special type of staph. One thing that was mentioned at the conference recently is patients who have multinuclear atrophy may have a much greater chance of having dental MARCONs or having these staph bacteria in their dental cavities. Have you seen this in patients with Lyme disease or predominantly with mold?
I'm not sure if they're more with Lyme or mold. Certainly I'd look for it regardless of the etiology of CIRS. This sounds almost like circular knowledge or logic, but if someone has MARCONs and we treat and it goes away, they're less likely to get it to come back. Whereas if someone has MARCONs and we treat and upon retesting it's positive, it makes it much, much more difficult to treat that person effectively. And that's where the dental MARCONs comes in, that if you have MARCONs hiding out in your teeth, in your jaw, somewhere else in your head, then it's going to keep seeding your nose. And we rarely see the same organism. I think I've only had 2 cases out of, I think, 400 or 500 cases where it's the same organism. Typically, it's a different organism that you find upon retesting. It's a slightly different with its resistance pattern.
Right. Okay. And so that's a really, really important and exciting new area. And I remember when I first started this training, Dr. Shoemaker told me, if you have a Lyme disease patient who's being treated by antibiotics and not improving, always look for MARCONs. And he said that in some cases where a lot of ILADS physicians, what we tend to do is give people a trial of rifampicin, and if they have a Herxheimer reaction, we assume they've got Bartonella. But in fact, according to Dr. Shoemaker, that's often a sign they have MARCONs. So that's another interesting little side point there. And the other thing that Dr. Shoemaker I've noticed has mentioned, and this might be an interesting talking point as well, is that a patient who's been treated for Lyme disease and co-infections, for instance, let's say they had Bartonella and Babesia and they had treatment with various antibiotics and they got better, and then many months down the track they become worse again. And often what some people are theorizing is that the Bartonella is coming out of the deep tissues or the Borrelia is reactivating. But according to Dr. Shoemaker, that's much more likely to be a mold exposure rather than actually all of a sudden a bacteria coming deep out of the tissues. Would you care to comment on that?
Yeah, absolutely. And not only is it more likely that it is a re-exposure to moldy environment, what I find is that when I see patients who are being treated and maybe they aren't even getting better, that their Lyme is pretty significant with symptoms that don't resolve well. Almost uniformly, those patients are in a moldy environment, and they're not going to get better as long as they're in their moldy environment, and they're not going to get better until the CIRS is treated. So that's the big challenge, is to get people to understand that their homes or their workplace might be making them very sick, and they have to leave for their health, or they have to find ways to treat and to improve the air quality in their environment.
Right. So this takes us to a little bit more of a holistic approach or a holistic model of Lyme disease. And what I've noticed is on a lot of forums on Facebook and other things, a lot of people, again, with Lyme disease start getting into despair when their antibiotic treatment is no longer working for them, and often they feel that these bacteria have won, they've taken over, and it's become impossible for antibiotics to have any effect. But really what you're saying is it may well be that those antibiotics have done their job, but rather they need to explore CIRS. Is that your thought?
Absolutely, and it is a holistic approach. And the idea that if someone has Lyme disease, that they have this Borrelia bacteria in their bodies and they have to go and attack it, and once they kill it, they're going to be better, I think is just deeply flawed. Part of the big reason why some people get very sick with Lyme disease or very sick with CIRS is because their immune system is not functioning optimally. If you remember, Dr. Shoemaker talks about CIRS as an immunological disorder, and it is. It's the immune system is not turning on the acquired immune response. You have that innate immune response going haywire and creating all this inflammation, whether it's due to Borrelia, Babesia, Bartonella, or water damaged buildings and all the 30-plus different inflammagens that can produce that response. The key is to get the body to calm down and to not have that untoward immunological response.
Mm-hmm. Yeah, so this inflammation that's gone awry, in a sense, Dr. Bernstein referred to it as sepsis light in his talk that he gave in Irvine, and what I saw in patients in intensive care who had sepsis and had recovered from sepsis through the use of IV antibiotics and inotropes and so on, was afterwards they often had some brain fog and some fatigue and so on. And you could say that that's kind of like a reasonable analogy for what might be happening in a lot of these chronic patients with Lyme disease, that they have antibiotics given for the Lyme and the co-infections, but then even when it's treated quite reasonably in some cases, they may still have this ongoing inflammatory response syndrome. And so if a person was concerned about that possibility, what sort of tests might they consider having done to just explore whether they may have an inflammatory response syndrome going on?
So if we're looking at whether or not someone has a CRS kind of inflammatory response, certainly looking at biomarkers such as TGF-beta1, looking at MMP9, which is a cytokine. I recently have started exploring some other TGF-beta1-like growth factors, GDF15, and macrophage inhibitory factor. And we may be having some additional biomarkers here in the U.S. where, with different lab companies changing their parameters and changing who sends their labs to what other labs, we're having some challenges with a few of the biomarkers and getting them done correctly. And so we're always on the lookout for other things. C4A, I find, is a great tool in helping to distinguish perhaps a little bit more if something is mold versus Lyme. I tend to see much higher C4A levels in mold patients than I do in Lyme patients.
Mm-hmm. So would you say maybe if the C4A is above around 10,000, would you say that's more suggestive of mold rather than Lyme?
I think that's probably that water damaged building is part of the etiology. I think that's a good kind of cutoff. Certainly if it's below that, it absolutely can be as well. And one thing to keep in mind, going back to the Marcons picture, is that sometimes when people have Marcons, it may cause a reduction in the C4A. So not until you treat this Marcons do you all of a sudden see this huge rise in C4A when you were maybe puzzling your head a little bit over whether or not the person had CRS to begin with. You treat the Marcons, and there you see the C4A rise to what it probably would have been.
Okay, so we've got this whole array of markers such as C4A and TGF-beta1 and MSH and so on, which we do with Quest, and generally MMP9 is run through LabCorp. But I'm just wondering, even before maybe patients have invest the funds in having that full workup, do you think it would be reasonable for them to do a visual contrast test, for instance, online? At survivingmold.com, that could be a reasonable screening test to start with if you're a Lyme patient, to think about whether you could have CIRS. And then the other test is the HLA genetics. So let's say if a patient has a multi-susceptible or a mold-susceptible gene type, would you say that would increase the likelihood that water damage buildings may be playing a part in their health, Sonia?
Certainly, and if an individual was curious as to whether or not they had CIRS and could it be due to mold or could it be due to Lyme, the first step is to look at the list of symptoms and to get a sense of, do they fit the picture? And the second step absolutely would be to do the visual contrast sensitivity test. But a negative test does not mean that someone doesn't have CIRS due to water damaged building or due to Lyme disease. The HLA, I find, is pretty helpful for me if I see a patient who has come in saying, I've been treated by these 4 other doctors for Lyme disease, and we do their HLA and they're double mold susceptible. I start to think, well, perhaps you've had Lyme and perhaps you have water damage, building exposure, and maybe it's those molds and other inflammagens that are suppressing your immune system so you can't get over the Lyme disease if it's still persistent. But it can help. Now, unfortunately, most of the time that I do the HLA testing, and I do it all the time, and I'm hoping it's going to help me to figure out, is someone more prone to have problems with mold or to Lyme. They usually have one of each, or they have a multi-susceptible, and it doesn't help in those cases. But sometimes it can be a tremendous help in figuring out where the cause
right.
is coming.
And so they can have that HLA test done with LabCorp, is that right? And it basically goes by the name HLA DRB1, DRB3, 4, and 5, and DQB1 gene testing. Is that correct?
That's correct.
Okay.
Here in the U.S., it's mostly we do it typically through LabCorp, but other labs can also do it.
Okay, great. Okay, and in Australia, the HLA gene testing can be requested as celiac gene serology, and it should be done through, gene testing rather, and it should be done through the Sonic group of labs, which includes Douglas Henry Moyer and Melbourne Pathology, and so on. So that can be quite useful. All right, I'm going to change gears here and take a couple of questions from the audience. Now, if anyone has any questions that you'd like to ask, we're a little low on time here, but if you'd like to put them in the questions window or in the chat window, and we'll try and answer a few here. So Rita Berman has asked, Sonia, can you discuss the gliotoxin derivative on the real-time lab test? They say it can be a toxin from Aspergillus, but also toxins from Candida are mentioned. Also, they say it can be found in the urine of those who have tested for other mycotoxins in the past. Is it a cross-reactor to other mycotoxins? Please discuss.
Well, unfortunately, I can't really do a whole lot of discussion about real-time labs because I just simply don't use the lab.
Yeah.
I'm convinced that the testing is a valid reflection of what's going on in the body. It doesn't have the kind of specificity that we're looking for, and there is, I believe, cross-reactivity so that you can't determine what is coming from actual toxins within the body versus what is being consumed in the diet, etc. How about you? What's your sense, Sandy?
Yeah, I think, well, the problem in CIRS is that patients can't excrete mycotoxins. So I think the fact that mycotoxins may be showing up in the urine is not going to be very specific for the people who are really having an inflammatory response syndrome. And Dr. Shoemaker's research has suggested that probably it's more related to food-based mycotoxins. And it's unknown whether they cause problems in some people or not. Now, I would say if one was going to use that test, the way to do it would be to do a provoked test after using a lot of binders such as cholestyramine and other detoxification methods, because and then looking at the change between the baseline level and the level after that, because it's probably the patients who have very low levels to start with, but then with provocation, the levels of mycotoxins can be seen to elevate. Are probably the ones who are the most sick. So that's one way of looking at it. There are still issues around the actual assay itself and which subforms of the mycotoxin is actually being tested for. So unlike you, Sonia, I don't use that testing, but I would feel that if someone doesn't have access to the other tests and that's the only test they have access to, that perhaps a provoked sample would be the way to go. You know, it's still not going to be very, very reliable, but it may give a bit more of a better indication. Just trying to be helpful there. So another question is the DNA connections Lyme panel worth it? So this is a new type of PCR testing. This patient, Chris Graber, already did IGNX and IGNX co-infections a few years back, but still wanting to explore the possibility he could have some active co-infections. Do you have any thoughts around that, Sonia?
Again, I have very little experience with DNA connections. Some of the more expensive tests I try to avoid for cost reasons for patients. I've seen a few panels come back from patients who have transferred their care to my practice and seen a broad range of positivity. So I don't know if it's truly that there is Ehrlichia and Babesia and Bartonella and Borrelia and Anaplasma all involved in one patient, or if the test is a little too robust. I just don't know. I've used a little bit more frequently Fry Labs test, which is also PCR DNA test, and they have two versions. One is a prokaryotic test, and the other one is a eukaryotic test. And he's finding some interesting things in the eukaryotic testing where there seems to be a lot of one organism or another. And so I'm getting some interesting results that seems to be more finding in multiple patients.
Okay, great. Thank you, Sonia. So I'm going to race through a couple of other questions here. When the C4A and TGF-beta levels have normalized, yet MSH has declined to 10, what might help to reverse this? VIP is in the normal range. My answer to that one would be VIP nasal spray. Absolutely. Is what needs to be used in that case. Let's go through. So this is one from Australia, from a Michelle Reardon. My daughter and I Okay.
My apologies.
That's all right. Yeah. Everyone awake now? My daughter, this is a question from Australia. My daughter and I were diagnosed with Stachybotrys atra in the house and are also positive for Borrelia, Babesia, and Bartonella. What other tests would you recommend, and how does one go about finding a reputable mold test? I think you've covered that to a certain degree already, but do you want to maybe just quickly answer that one, Sonia?
And that's from Australia?
Yeah.
Yeah, and how does someone find a reputable mold test? I'm not sure if any...
We're doing Quest. We're sending labs to Quest here in Melbourne, Sydney, and the Sunshine Coast, and myself and Dr. Kim are the main physicians who are using this testing. My first comment was to find a reputable doctor like yourself, like Janet Kim, and certainly do the lab testing that they recommend. Yeah. That's it. We do have another lab here, Sonia, who are doing the testing called NutriPath. We've done some comparative studies, and so far the correlation hasn't been as good as we'd like it to be. All right. Would you like to talk a bit about hyperbaric oxygen? This is probably the last question we'll take. Hyperbaric oxygen as a possible treatment for Lyme or mold. There's two people who asked that, in fact.
So hyperbaric oxygen, there's some studies that came out of Texas looking at hyperbaric for Lyme disease. And I've had some success using hyperbaric in patients with some persistent Lyme. I tend to reserve it for if I'm using IV antibiotics. I figure if I'm using IV antibiotics, I might as well pull out all the stops and help their body and their immune system fight the Borrelia as well as possible. The issue, and I don't know about Australia, but certainly in the U.S., is the accessibility of hyperbaric chambers. If you go to a not sufficient amount of pressure, so a low ATA, you can have problems. If you go with too high of an ATA, you can have problems. The right perfect amount of ATA is around 2 to 2.4, and it's not just one treatment. It's multiple. It's daily. Typically 20 to 30 what are called dives. But when it works really nicely. It can do a very good job. The only caveat I would say is that some people believe that if you have Babesia, doing hyperbaric might be a problem because you're increasing the oxygenation in the red cells and might feed the Babesia, might stimulate Babesia growth.
Okay, great. Thank you for that. Now, I believe Dr. Patel's just joined us. Now, it's possible there's been a mix-up with time, but let's see if we can get him on for a couple of comments. Can you put your webcam on, please, Raj?
Oh, yeah, here we go.
Okay, Raj Patel from Redwood, California. How are you?
Hey, I'm doing well.
That's good. Did I give you the wrong time? We're just actually at the end here, but that's okay. So I do apologize if I mucked it up. But do you have any comments you'd like to make on Lyme and CIRS?
I just came in the last few minutes here, so I was just listening to Sonia's input on HBOT for Lyme.
Yeah, okay. And do you have any, I think there is one question for you here. I'll read that one out for you. I think a patient who is considering seeing you. I'll just scroll down. This is a question for Dr. Patel. I have chronic Lyme and co-infections for 20 plus years and now believe I also have CIRS. I have not been diagnosed as yet. I live in Ontario, Canada and have a LLND. It is important for me to be diagnosed and treated for CIRS by a doctor who is both an LLMD and a Schumacher practitioner, or is a Schumacher practitioner only sufficient? So I guess this is a question really around, what sort of expertise or what sort of practitioner would this patient need if they've got a bit of a complex puzzle here of Lyme and co-infections and CIRS. Do you have any thoughts on that, Raj?
Yeah, basically, if I understand the question, they're asking how to go about when you have both mold and Lyme ongoing simultaneously. The typical approach that I take with most of my patients is first and foremost identify whether they truly have mold illness. So if they're having a chronic inflammatory response to a moldy, water-damaged environment, and you have inflammatory markers that are responding accordingly, then obviously the first thing to do is to get into a clean environment. Because I think a key part in the success of treating Lyme is being able to control and minimize the amount of inflammation in the body. So once you're out of the moldy environment and you've done a trial of cholestyramine, a lot of the markers will come down. Now, if you've got active Lyme disease simultaneously, the markers will probably not come down completely to normal. But as long as they come down significantly, it's telling you that the inflammation has been reduced quite a bit, and then that, to me, many times, allows the door to open to be able to successfully go after the Lyme infections.
Okay, great. So you find, in a sense, a combination of using the CIRS treatment protocol plus or minus some herbal treatments you would use more. I think you told me in Irvine you would use more regularly than antibiotics.
Yeah, I think that there's a lot of different ways of going after Lyme once the inflammation's been managed, and most of those different avenues will work. If someone wants a purely herbal approach, that certainly does work. You can do antibiotics, you can do a combination. You can introduce other alternative therapies like biooxidative therapies if someone's interested in that. But I think really the key is first getting into a clean environment, get the inflammation down, then go after the Lyme infections and any other infectious components that you're finding, whether there's chronic viruses, parasites, mycoplasma, chlamydia. And once the infectious load has been eradicated, what I find is that the inflammatory markers come down completely within the range. And then that opens the door for us to be able to use the VIP very successfully.
Okay, great. So that's a really helpful comment there, Dr. Patel. So it sounds like if someone is currently not seeing a Shoemaker certified physician and maybe they want to find out whether going down that pathway may be worthwhile for them in a chronic Lyme sort of situation, I think I suggested that maybe a VCS test, which they could do online at surviving mold, could be of some benefit, although Sonia mentioned that there is a problem with false negatives there at times. But that could be an option to do that. It could be also worth having a look at their HLA genetics, which could possibly be done through their local doctor through LabCorp or Quest, and any other sort of screening modalities you'd recommend for a person just to help with their decision making of whether they should invest the time and money to go and see a Shoemaker physician.
Well, I think one of the things that I do to determine whether there truly is a mold illness or not is this provocative challenge, where we'll do the baseline markers, and depending on what's available in your area, C4A, TGF-beta 1, MMP9, VCS. And then if they are elevated and you're suspecting that there's a mold problem, get out of the moldy environment, go on cholestyramine for a few weeks and then repeat the labs. And if they drop dramatically, that pretty much tells you that you've got mold illness.
Okay.
And then if you wanted to go back into the house for a few days without cholestyramine, typically 5 days, and then repeat the labs again, and they go shooting back up, then you know that you're reacting to the house and that there is a certain amount of moisture damage in there.
Right. Okay. So that's a provocative use of the C4A testing, and that's a bit of a luxury that probably US patients only would have. Certainly not possible over here in Australia due to the large cost and expense of the testing. But that's really interesting that they can do that. And Sonia, did you have any other comments about that dilemma if someone may have chronic Lyme or post Lyme and they're deciding as to whether they should invest in seeing a shoemaker physician? How they might make that decision?
One of the things that I think is really useful is to test the place where you think you might be feeling worse and your mold exposure might be coming from. If you think it's your home, do a mold test, do a Hertz-Me test, do an ERMI test if you need to, but I think just a simple Hertz-Me test, and if you have high score on your Hertz-Me test, you know that there's a problem, and whether it's Lyme and mold or just mold, you know mold is a big part of that problem. And like Raj, I also do like treating the mold first before you really, if you don't calm that inflammation down, it's much more difficult to go after the Borrelia.
Okay, great. So I hope this has helped a lot. Now, someone has just asked what inflammatory markers is Dr. Patel referring to. I believe it was more the C4A you were referring to, Dr. Patel, or was there others?
That's correct. Yeah, the four main markers that I use is C4A, TGF-beta1, MMP9, and the VCS test.
Okay, so you just have that sort of reduced panel that you do for people. Okay, great. So I hope this has been really helpful for people to kind of work their way through this maze of Lyme disease and mold. And I really appreciate Dr. Patel popping in at the end. You added a little gem, so that was rather nice. I'm just going to finish up by talking about the course for a moment again, and yeah. So if people are joining this webinar and think they may have Lyme disease and want to know more about CIRS as well, the course could help you in that it helps you to understand what CIRS is essentially and how it interacts with Lyme disease. And by going through the course, you get a bit more of an understanding of what the different steps of assessment for CIRS or mold are. And that may help you in your decision making to know where you're going further, especially if you feel like you've reached the end of the road in terms of antibiotic treatments, etc. So if you think this course may be helpful for you, we do have a coupon code CIRS Lyme 25 where you get a 25% discount off the normal price for the next 24 hours, and the link is there on the top of the slide, moldillnessmadesimple.com/sign up. And yeah, this will probably be the last discount code for some time. The next, we're going to be doing some more webinars. The next one is going to be in late November rather, with Dr. Samantha Clark, who's a psychologist. And in that webinar, we're going to be talking specifically around the emotional impact of CIRS and how people can help deal with some of the anxiety and distress that comes around that. So I hope that's going to be really useful. That'll be on November the 25th, and we'll be sending out some information about that soon. So I'd like to give a big thanks to Dr. Sonia Rapaport and Dr. Raj Patel for joining me, and I really, really hope that this discussion has been helpful for people. There will be a replay which we will be offering to people who have signed up to our mailing list and also who have signed up to the course. So again, thank you very much, Sonia and Raj, and hope you have a great rest of the day and look forward to catching up with you guys soon. All right.
It's a pleasure talking with you, Sandy.
Thanks, Sonia. Thank you, Raj. Nice to see you.
Thank you.
Bye for now.